out bits of tissue from their body. Okay, the real problem is the way she breathes and the way she uses her muscles. Okay, you can also see her facial development is at an angle and it's restricted. So what do? We
Hello, everyone. Welcome to our diagnosis and management of dental implants, of soft tissue problems around dental implants and teeth. It's great to have you with us this evening on the East Coast and this afternoon on the West Coast. Just before we get started, just a couple of quick housekeeping points. We're going to be answering any questions live during the presentation. You can utilize the Q&A feature on the bottom of your screen. You can click on it, put a question, and we'll try to get back to you during the presentation and answer those questions. We will not be seeing or receiving any of the messages on the chat feature, so please don't use that on the screen. And if you have any questions after the course, or if you want to know regarding our upcoming courses, feel free to follow us on Instagram or Facebook, and we'd be more than happy to answer your questions. Regarding your CE credits, Dentsply Sirona will be providing you with these CE credits early next week. When we're done with the presentation, we're going to be giving you a CE code. Please do not close your screen because you'll be automatically directed to a page where it'll ask you for that code so you can put it in there. I want to take this opportunity on behalf of Dr. Bamanesh and myself and the Cedar Cancer Foundation to say thank you for your generous support and donation for this cause. At the end of the day, that's what we're all here gathered for, to try to raise funds and help the people and the most vulnerable amongst us during these difficult times. We come to you with greetings from Montreal. For those who are not from the Montreal area, about half of the participants on this webinar are from out of town. So we like to think of ourselves as a beautiful outdoor social city. Currently not the situation by any stretch of the imagination, like anywhere else. We're under lockdown mode currently. But if it's in your plans in the upcoming year for a summer vacation, think about coming to Montreal. This is our famous Jazz Fest. About 1 million people come into town. Outdoor activity, outdoor concerts. We like to think of ourselves as the Paris of North America with the mix of our French heritage. We just celebrated our 375th birthday a few years ago. We're a waterfront city, so if you're an outdoorsy kind of person, by all means, maybe you can plan your next vacation and think of us here in Montreal. On the flip side, if you like the cold, then maybe come during the wintertime, January or February. But if you're trying to get away from the cold, definitely don't recommend coming in the wintertime. Diagnosis and management of soft tissue problems, both around teeth and around dental implants. Game plan for today, we're going to show you some of the conclusions right off the get-go. And I do understand there's a diverse group of doctors on this call. There are doctors who don't do any surgeries. There's doctors who are more beginners and getting introduced into surgery. We also have a lot of specialists on the call, periodontists and oral surgeons. So what I do share with you is just to give you a perspective, an idea about different possibilities and approaches that are out there. So you have an idea of what kind of tools could be potentially in your armamentarium. And by your armamentarium, I mean your team. So if you're the person doing the surgery, or if you're a restorative doctor working with a surgeon, as a team, these are different options that you guys have. By no means am I advocating to go out on first day back and start doing these more advanced surgeries if you're just getting started into surgery. We're going to be looking at some definitions and examinations and solutions that are going to build the groundwork for us to be able to build from, and then develop more into biological principles and how they relate to treatment planning, treatment execution, and treatment success. And then we're going to look at some treatment cases together, some treatment algorithms, and we'll do some polling together. So it'll be kind of exciting. So if we're starting off with this first case here, this is a scenario where you've got advanced recession on multiple teeth. We have lack of attached gingiva. We have lack of connective tissue, lack of keratinized tissue. The important thing that I want you to try to pay attention to and try to develop the comfort in seeing these cases in your practice is whenever one sees a case like this, and it's not uncommon to focus on the molar because that's the most advanced, the most severe case, but to try to imagine the picture on the right when you're looking at the picture on the left. Because underneath this recession, this is the osseous defect that we have. This is the severity of the osseous dehiscences that are present. And if you look at the molar, what may seem not such a severe case, this is the severity in terms of when we look at the furcation involvement on that tooth. So Willis talked about how whenever you see a recession and you look at the gingival level, imagine the osseous contour being at least 3 millimeters, if not more, apical to that. So when we look at that, looking at the literature, kind of makes sense to see where the bone level is relative to each one of these cases. And it's in some cases, it's even more than 3 millimeters, depending on root prominence and tooth position. In this particular case, a connective tissue graft was utilized from the palate. The tissue was closed, primary closure was obtained, and we got great result. Is this success? Depends how you look at success. Surgically, yes, we managed to get success. We got great coverage and we got nice thick tissue. But from a patient outcome and patient management, we're far from success. This picture is taken immediately after cleaning that patient had come in, and this is 3 years after surgery. So if at 3 years after surgery, the patient's hygiene is at a point where we're getting such amount of bleeding following regular routine maintenance, we have a problem. And this is the kind of thing we're going to be looking at where surgical success does not end at the end of surgery. It's only part of the puzzle as we look at overall success and patient outcome regarding maintenance, regarding follow-up, regarding adaptation and behaviors and expectation from the clinician team and from the patient themselves. Can we get this around dental implants? The answer is yes. So if we're looking at a case up here on top, this implant was placed. There's an inadequate amount of tissue around this implant before it goes in for final restoration. And this tissue is nothing more than alveolar mucosa. That tissue is not going to be sturdy long term. It's not going to respond well long term. And we're going to look at some literature together on that. But the important thing is we need to know we have the armamentarium, the tools to be able to stabilize this situation. In this particular case, a free gingival graft was utilized, and this is the outcome we get. Could it be better? Of course. This is not that aesthetic of an outcome. It's a free gingival graft, so we can always see the white patchiness. We see the scar tissue formation on the area. We see tissue contraction, and it kind of looks like that white blob that no one really likes. But it's a treatment outcome, and there's specific indications. Maybe not this kind of a case would be the ideal, but there's other cases which we're going to show you that this could be a good solution. What about connective tissue around implants? This is our go-to, typically speaking. This is a case where at the time of phase 2 procedure on these implants, you can see how thin the tissue is. You can see the cover screw almost coming through, the gray hue to it. The surgical site's prepared, connective tissue graft is tucked under, the area is closed up, and this is the result we get. Much better than the previous case, much more aesthetic. Not that aesthetics is a concern in this scenario, it's in the mandible and the posterior, but again, just to give you ideas of what kind of treatment solutions are out there. So now when we look at these cases, these are the most common questions we get. Questions regarding gingival biotype and how does it associate relative to gingival recession. We're going to be talking about this. Questions regarding attached gingiva versus connective versus keratinized gingiva, as it relates to health and prevention of future recession. We're going to look at this critical concept as it comes to thickness of the gingiva and the underlying alveolar bone and how they relate and interplay with each other. Of course, we're going to look at fictitious behavior, trauma, toothbrush trauma, and so on, and how they correlate with gingival recession. We're going to talk about this famous question regarding restorative margins when a full contour crown, let's say, is performed. What happens if the gingival margin is intrasulcular or subgingival? How does it intercorrelate regarding orthodontic movement and teeth that have inadequate attached gingiva or thin gingiva or a mucogingival defect. And what is a mucogingival defect is another thing we're going to be looking at, and how it correlates with progression of disease. So we had a a webinar a few days ago regarding the new classification of periodontal disease. And we focused mostly on a particular aspect on periodontitis. We had another session which was regarding peri-implant diseases and health. This is more when we look at it from a particular perspective from mucogingival problems. When we compare where we come from and where we are today regarding our understanding, our science, and the literature, it's made a huge impact. So what we used to once call gingival soft tissue recessions only down here, this is what it's expanded into. So this entire section regarding periodontal biotype didn't even exist when we looked at our previous classification from 1999. In 2018, this was brought out as a whole new section. When we look at what used to be section 1 with 2 subtypes, now has become section 2, and we have 6 extra subtypes that are added on. And this brings the value and the importance to our comprehension and understanding of the science and how that correlates with what we see clinically. So we're going to spend some time looking at recession classification. As many of you know, Miller classification is no longer utilized. We talk about the chiral classification, recession type 1, 2, and 3. We're going to spend some time on that. The importance of gingival thickness versus gingival width. This whole notion of non-carious cervical lesions or cervical carious lesions, and smile index and hypersensitivity. So if we look at a case like this, it's fairly evident the freedom pool that's visible in this area. We can appreciate how we've got a wide band of keratinized gingiva on the adjacent teeth and how the mucogingival junction dips down. We have no attached gingiva, no keratinized gingiva, and we have a freedom pool. So these are the kind of things where we want to train our eyes to look more into versus just looking at the teeth, looking at the recession. This tooth has maybe about 1.5 millimeter, a 2 millimeter recession. That's not the big problem. The big problem is what's up here, what's not on the white area, what's in the pink area. This is another tooth on the mandible. I apologize for the poor picture quality with all these bubbles. But it's just to demonstrate certain areas in the mouth where we see these conditions most prevalently as it comes down to the incisor region and the mandibular area. This is also complicated by another factor, which is shallow vestibule. We almost have no vestibule here. And in these cases, if you were to pull on the lip clinically, you'll see the tissue actually pull back the gingival margin off the tooth. Can you get this kind of problem around implants? Absolutely. And not only can you get them around implants, but it actually becomes much more complicated to manage, to deal with, and in terms of overall case success. So it's important to appreciate the notion that we need to have good soft tissue, but more importantly, as we talk about in our bone regeneration webinar, the underlying bone is even more critical when you're talking about dental implants, their positioning, their placement, as well as the overlying soft tissue. But a lot of times when we see these gray hue coming through the gingiva down here, that just means this bone does not stop here. It actually extends down. So we have a large dehiscence on that implant, and the soft tissue is a contributing factor, of course. When we look at a case like this, it's important to appreciate that just because we may not have a big recession or not have a recession at all, let's say if we're looking at the canine, or a mild recession if we're looking at the adjacent teeth, that there is a mucogingival defect here. And the mucogingival defect's represented by the lack of attached gingiva around these teeth. And I'm going to demonstrate a little clinical exam that you can utilize to appreciate these and the relative consequences associated with it. People ask this question, can you brush away your gums? The answer is absolutely yes. But the tricky part is, when is it due to aggressive toothbrushing and when is it due to lack of toothbrushing, such as non-carious lesions, abfraction lesions, and so on. So one of the telltale signs is the gingival health around the recession. So when you look at the gingival health around the recession here, of course, we see these large abrasion lesions where you've got concavities developed inside the root. You've got these cup-shaped lesions as opposed to the notch-shaped lesions that we get in non-carious lesions or fractional lesions. But the most important thing is the gingiva is fairly healthy. It's nice and pink. We don't see much plaque. So when you see this, the importance of being able to distinguish between the two is a direct correlation to the treatment outcome you're going to propose to the patient. So imagine the catastrophic event if we look at a patient and we misdiagnose the situation. So let's use this as an example. If we look at this, we have fair amount of comfort to tell the patient that you need to take it easy on the brushing. You shouldn't be brushing 5-6 times a day. You need to practice proper toothbrush technique because we're assured that this patient is on one end of the spectrum and we need to kind of bring them back down to where they need to be. Versus if we have this kind of a patient in our chair and we think it's because of aggressive toothbrushing and we tell this patient to take it easy, brush less, and you need to use a softer toothbrush, or you need to use a technique which is more delicate. Whereas if you look and pay attention to the gingival margin around this recession, it's extremely inflamed. We have a lot of redness, a lot of irritation, and this is a completely different case compared to the previous one. This case is actually itching for proper hygiene because of that inflammation. So it's very important to establish where we are in that cascade of inflammatory process relative to hygiene, relative to tissue biotype, so we can fine-tune the techniques and the instructions we're going to give those patients. So this patient, if anything, needs to practice more on their hygiene. They need to brush more. They need to brush more frequently with the proper technique to get this inflammation under control. And that's before we even start contemplating any sort of surgical intervention. When do we see a lot of these particular kind of cases? Sometimes around orthodontic cases. So this famous question, can orthodontic treatment cause recession? The answer is a yes and a no, because orthodontic by itself cannot cause recession. However, if you introduce enough bad variables around the situation, by all means, it can accelerate tissue breakdown if it's not managed in a proper fashion. And we're going to look at some literature when it comes to that. But as a general rule of thumb, you want to make sure you've built your foundation strong enough before you start moving teeth around, especially in those areas where the teeth are questionable, the soft tissue, and it feels it's borderline. You're best off manage the soft tissue, build the foundation before you start building your teeth positioning. Never do it the other way around. So what happens when we start looking at teeth in the posterior region where they have multi-rooted teeth and they have a furcation? So these particular cases, something as innocent as a 2 or 3 millimeter gingival recession can turn out to be a catastrophic outcome for a molar tooth if the combination of events presents itself where you have a recession in the wrong spot, i.e. around the furcation area. You have a tooth that has divergent root and that has a short root trunk where the furcation is not that far away from the gingival margin. So in cases like this, something as innocent as a soft tissue lesion can actually end up leading to a complete loss of a molar tooth. So, but it is important to manage these, to look around in the mouth, to train your staff, your hygienist, that are normally the first line of defense for these cases, that are monitoring these in the general dentist practice or in the ortho practice, that spend most amount of time with the patient, because we can get recession on pretty much any tooth in the mouth. It's not only found on the lower premolars or the maxillary premolars or canines. We see them everywhere. So the question becomes, what's the relevance? How big or how bad can this problem become? So literature is showing us that if a patient, that if a patient has good health, oral health, and despite the lack of keratinized tissue, if they can maintain impeccable oral hygiene, go to the regular professional hygiene appointments with their dentist, as well as be able to maintain that good oral hygiene in the absence of other factors, risk factors, they can actually maintain these areas fairly well. However, if there is a slight change in any one of those variables, then this is when intervention needs to step in. So if a patient oral hygiene habits change, and that means either home hygiene or professional hygiene. If a patient's medical history changes, which can have a consequence on their habits. So they develop medical conditions or they have to start taking medication that could have a secondary side effect on salivary flow, salivary consistency, manual dexterity, and so on and so forth. That is a flag raiser. Of course, if we need to do something from a professional perspective, if we need to, if we determine a patient needs orthodontic care, they need implant treatments, they need restorative treatment on a specific tooth, those are scenarios where all of a sudden something that we've been able to maintain for many, many years, now our patient at the age of 50, we decide now we need to intervene and start doing a gum graft. And they might say, but how come? But this is the reason why. Because in this scenario, the environment, the microenvironment is changing. So part of this new classification, we talk about periodontal biotypes. Periodontal biotypes, we're talking about gingival thickness versus tissue width. We talk about bone morphology and morphotype, as well as tooth positioning and tooth dimension. And when we look at tissue biotype, it really breaks down into 3 segments. Category 1 is the famous thin scallop. So you see very, very triangular shaped teeth. You see very thin tissue all around. We typically see a narrow zone of keratinized tissue. Typically, the contact point between teeth is more at the incisal edges, and we don't see much convexity around the teeth, around the cervical area. And the important thing is to understand that underneath this, we have very thin bone. So if it's thin on the outside, it's thin on the inside. We can see the root prominence coming right through the tissue, and you can actually see the teeth almost underneath the gum. The complete opposite would be the thick, flat biotype, where teeth are more square shaped as opposed to rectangular. The tissue contact is almost at the gingival level versus being at the incisal edge. We have thicker, broader bands of keratinized tissue, thick tissue biotype, and thick bone underneath. So it's not uncommon to see osseous ledges under these scenarios, these kind of cases. And then we've got our third scenario, which is kind of somewhere in between, where we see the thick scallop. So you've got kind of the best of both worlds, where your tissue is thicker, but you still have the scallops. You've got the triangular shaped teeth, but you've got more underlying bone and a thicker band of keratinized gingiva. Why is it important to know this? Well, the reality is you're not going to get one case or another. You're going to get a blend, a different variation of a spectrum of gray as opposed to the black and white scenarios. And a lot of times you might notice different areas of the mouth are closer to different types. So that comes into direct correlation with how you're going to manage it, what your expectation is, what your expectation is of treatment outcome. So if you look at this case here, the tissue is fairly thin. You can see the probe. This case here, you can't see the probe, but you need to understand this is like that thick scallop version because the tissue is blanching pretty heavily. And if the tissue is blanching, it's the same way when you squeeze your nail bed and you get blanching under your nail bed. We're actually getting collapse of the vasculature. So that's a telltale sign that this is a high risk area. We might get further tissue breakdown. So what are some of these risk factors for gingival recession? Like we talked about, thin biotype, absence of attached gingiva, and a reduced thickness of the alveolar bone and the overlying soft tissue. So it's not just purely about keratinized tissue like it used to be back in the days. Now, the impact of cervical restorative margins, as we talked about, there's abundance of literature that shows us how in the absence of adequate tissue thickness, any intracellular margin that's placed into the sulcus can actually increase gingival recession and therefore gingival inflammation. And that could lead to further tissue breakdown, more recession, and which could eventually lead to more bone loss. So sites where a gingival, a restorative margin is going to be placed sub-G, those sites always need to be developed if they're inadequate in dimension. And I'm going to show you a literature on a coming slide, talks about a couple of numbers for that. We talked about the impact of orthodontic tooth movement. Now, we need to remember one concept. When we're back in dental school, we were always taught that if your recession is your gingival dimensions are borderline on the buccal and you're moving the teeth lingually, you can kind of ride it out and monitor the situation. But if you're inadequate on the buccal and you're going to push the tooth more buccally, then by all means you have to treat it first. But here's a caveat. You need to ask yourself not so much which direction the tooth movement is going to affect the gum, which obviously that goes without saying, but you need to ask yourself the question, considering the soft tissue we have on the buccal, and if in fact is adequate to a certain degree, how resilient is the soft tissue to maintain the forces and the impact of orthodontic tooth movement? And remember, orthodontic tooth movement induces osseous inflammatory response. That's how we get teeth to move. As long as that osseous inflammatory response stays within the bone and not the soft tissue, we're perfectly fine. The moment that inflammation breaks off and it comes into the soft tissue area, that's where we get rapid progressive attachment loss. So things such as hygiene become a question, because typically we do orthodontic teeth movement because teeth are crowded. They're not in their ideal position. They're twisted, they're turned, they're buccally positioned, they're lingually positioned. There's root prominences at play. And a lot of times, unless you're using some sort of a clear aligner, if we put any sort of brackets on or any sort of bonding on the teeth, that's only going to complicate hygiene and it's going to build more surface to get plaque accumulation. So these are things that we need to think about when we're looking at this from a multi-disciplinary approach and asking ourselves the question, do I need to treat the site prior to starting orthodontic tooth movement? And it's very critical that if it does need the treatment to be done before starting orthodontic tooth movement. So this concept of attached gingiva, it is not synonymous with keratinized gingiva. Attached gingiva is keratinized gingiva minus the area which is probable. So what does that mean? If we're looking at an area where this is the gingival margin and comes all the way down to the mucogingival junction, when you look at this, this is all keratinized gingiva from the outside, if you're looking from here. But when you use a probing depth and you come down, if theoretically your probe depth would end somewhere over here, that means your keratinized gingiva from here up is non-attached. So the only thing left attached is the part down here. Now, this is fairly easy to do if you have a patient like this, such as this diagram, which has clear delineated mucogingival junctions. In most cases, it's difficult. Some cases, if you're lucky, you can see the mucogingival junction, your probe surpasses it, and you can easily tell this is a mucogingival defect. In other cases, what we need to do is utilize the Glickman stretch test, where we place the probe on the tissue, alveolar mucosa, we move it up and down, and we look at the gingival margin. If the gingival margin moves up and down as we pull the tissue down in the vestibule, we know nothing is attached here. So if we do the same exercise, we look at the tissue up here as we do it down here, and it gives us an idea of what's moving. And if it moves, then we don't have adequate attached gingiva. That's what we call a mucogingival defect. So what's the objective? The indication and the objective are directly correlated. So we need to establish adequate width and thickness, no longer just width, but also thickness of attached tissue and keratinized tissue. We need to obviously eliminate any aberrant frenum pull or muscle pull, ideally correct the gingival recession, and as much as possible, try to get coronal repositioning so we can actually eliminate the recession, the root coverage. So the most common indications we see is, like we said, preventing recession, restorative margins, if we're talking about crown and bridge work. Another key part is connectors on removable dentures. Those clasps on a lower partial, classically in a posterior bilateral saddle, where we've got the premolars as the abutment, and typically those teeth have the least amount of attached tissue in the mouth, and patients come in, they use their nails to get under the clasp and pop them off and on. Those are areas typically, before planning the denture fabrication, we need to augment those sites if they're deficient. We see them sometimes after the fact, but then it complicates things because now once the tissue is plumped out, the denture has to be adjusted, and sometimes it's not fun when it involves the metal component of it. Tooth movement into areas where there's osseous dehiscence, like we talked about in orthodontics, and in cases around dental implants where we need to develop a site to make sure we've got adequate width and adequate thickness of tissue. What are some of the most common techniques we utilize? There's an abundance of these. And when we look at these from laterally moving, coronally moving tissue, looking at the traditional free gingival graft and the connective tissue grafts, there's abundance. One of the most common ones we always hear about is the pinhole technique. And the pinhole technique basically is a type of coronally positioned flap. It's got a proprietary approach where, as opposed to we come in from the gingival margin, the surgical entry site's made through the depth of the vestibule. We also have the Vistal technique, exactly the same thing again. It's done through the base of the vestibule. The technique doesn't matter as much as the tissue manipulation matters. If you come in from the top or you come in from the bottom or you come in from the side, the point is, if you're moving that tissue, you need to follow and respect biological principles to make sure that tissue moves in the way you want it and it stays healthy and gets a good amount of blood supply. When you look at all of these different types of surgical procedures, the two most common ones are the free gingival graft and the connective tissue graft. And even if you're talking about dermis, alloderm, all these different kinds of synthetic or tissue bank grafts, those basically mimic a connective tissue or a coronally positioned flap with an underlying synthetic or donor tissue underneath. So if we're looking at a free gingival graft, we start with the most basic. Most common indication is to increase zone of kg, to eliminate any sort of muscle or freedom pool. And one of the key features of this is to deepen the vestibule. We can obviously repair gingival clefts with it, but keep in mind deepening of the vestibule and increase of kg are the two most go-to reasons we utilize this procedure. So if we look at a case like this, what we do get is a solid band of keratinized tissue, but like I said earlier, it's not pretty, doesn't look aesthetic, it's very patchy, blobby-like, and it's very visible for a patient. Now, do we increase zone of kg? Of course, that's the best technique to utilize to try to thicken the tissue and get a lot of abundance. But can we get predictable amount of root coverage? The answer is no. We do get some root coverage, but we don't get as much root coverage as if we had done a connective tissue graft in this case. So when we talk about root coverage, then what is root coverage? What are the reasons and what are the purposes or indications we do to get root coverage? Obviously, aesthetic is the first thing people notice. Increasing attached gingiva, eliminating root sensitivity, and also eliminating defects related to root caries or abrasion or abfractions. One of the things to remember is when we talk about root sensitivity and connective tissue grafting, it's always important to maintain an idea of where the root sensitivity is coming from and what kind of recession defect we have. And we're going to talk a bit about that. So classically, we used to look at a situation like this and look at the gum graft done, and we used to stop right there and say, okay, this is a fairly good outcome. This is a connective tissue graft. The area is like, we've got a nice band of tissue around it. We've got good root coverage, and we wouldn't look at any other parameter. The important thing based on our understanding today is we need to concentrate on the parameter, not just on apical coronal coverage, but also buccolingual tissue thickness. So it's one thing to get a site where it's barely covered and the tissue is so thin, like the scenario I showed you earlier with the probe, you can actually see the probe right through. Do you think that's going to be resistant and resilient long term? Probably not as much as if you can get a nice thick graft, place the probe afterwards, and not be able to see it. So getting that tissue volume is a key indicator that we're looking for more and more nowadays to be able to appreciate and develop a site that's going to be more resistant to further tissue breakdown. Key thing to remember all the time when we talk about these recession defects and treatment management, never lose sight of the underlying etiology. So if that scenario we talked about where the patient has toothbrush trauma, remember we got to address the toothbrush itself before we do the gum graft. And if we take care of the gum graft and the patient keeps utilizing improper technique or aggressive toothbrushing, problem's going to come back down the line. If it's due to poor oral hygiene, if it's calculus, if it's tissue inflammation, that has to be addressed before we attempt gum grafting. Same thing with tooth positioning. Unless we address the underlying problem where eventually that patient gets some sort of orthodontic treatment, then there's always a higher risk that the problem may come back unless we manage all the contributing factors. So now let's look at these classifications that we were talking about. The Miller classification versus the Chiaro classification. I'm going to start off with the Miller because everyone's accustomed to the Miller. We're going to do a quick review and then I'm going to correlate it how it changes with the Chiaro classification. So the Miller classification, as everyone knows, it's when the recession that does not reach the mucogingival junction. So it's short of the mucogingival junction. That's a class 1. A class 2 is when the recession actually meets the mucogingival junction. Now, in both of these cases, the class 1 and the class 2, we have zero loss of interproximal tissue. Once we start getting loss of interproximal tissue, then let's say in a case like this here or a case like this is entering into class 3. So class 3 automatically means we've lost interproximal tissue and we have a recession. So it doesn't matter if the recession's at the mucogingival junction or short of the mucogingival junction. Because we've lost interproximal tissue, we are an automatic Miller 3. And a Miller 4 is basically an exasperated Miller 3 to the point where we no longer have tissue harmony. So if I just come back real quick to a class 3 Miller, the tissue still looks parabolic. We still have scalloping of the soft tissue. In a class 4, the recession is so much more advanced, the interproximal loss of tissue is so much more advanced, where we have an L-shaped recession or sometimes a complete flat recession. Now, as we talked about classification in the other webinar, classifications are only as good as if they have a clinical implication associated to them. So having 5 or 6 or 7 different types of Miller recession defects doesn't do us any good if the treatment outcome becomes only 3 different things, right? So that's where, based on the discussion and the consensus that came out of the 2017 consensus report, it was established that we're only going to have 3 types of recession moving forward. The Chiaro classification. So Chiaro classification recession type 1, that's RT1, is basically what the previous Miller 1 and Miller 2 were. We have interproximal tissue, no loss of interproximal tissue. We just have recession. It may or may not reach the mucogingival junction. A Chiaro type 2 basically means we have loss of interproximal tissue, which is what we had the Miller type 3 before. And then a Chiaro 3 is the same as a Miller 4, where there's absolutely no chance of getting root coverage. Typically, people ask, well, what's the percentage of root coverage we can get? And is it 70%? Is it 75%? Well, the precession is a variable and function of the interproximal tissue height. So think about this for a second. People who go camping, they put up a tent, and you want to have a 6-foot tent where you can stand up inside of it, but you put your tent and it stays at 4 feet. What's causing that fabric to stay at 4? It's the tent poles. So if you have 4 feet tent poles, you can't have your tent sitting up 6 feet tall. When you drop it, it finds the tent poles, and then you get a parabolic shape. If you put a 6-foot tent pole and then you put a tent on it, well, it stays up at 6 feet. What if you have a 6-foot tent pole on one side and a 4-foot tent pole on the other side? Well, your tent's going to kind of look funny a little bit, right? The tent pole in our cases with patients is literally the interproximal tissue. So when your interproximal tissue is lower, your gingival margin is going to be lower. If your interproximal tissue is going to be higher, your gingival margin is going to be higher. That's what's going to dictate how much recession coverage you can get with the typical Chiaro 2 or the Miller 3 recessions. So now let's do this exercise. We're going to do a little poll together. What Chiaro classification would you say this is? Right over here. I'm going to post a question and then we're going to see what you guys think. So you should all have access to a little questionnaire to start putting the answers in. Remember, this is a Chiaro classification. Chiaro 1 is the previous Miller 1 and Miller 2. Chiaro 2 is the previous Miller 3. And Chiaro 3 is the previous Miller 4. So let's end the poll. Let's see what the results are like. And we have an astounding 70% that said this is a recession type 2. And the answer is absolutely correct. So you can appreciate the interproximal tissue loss. You can see the mucogingival junction riding up. We have interproximal tissue loss on both of these teeth. And so therefore, this is automatically a Chiro 2. So can we get root coverage on this? Probably just a little bit, not a lot. We can get quite a bit up here, but a little bit here. But can we get 100%? Absolutely not, because we're missing our tentacles on the sides. So let's look at another case together. What would be the best treatment choice in this case over here? Now, try to put everything together. We're looking at recession level. We're looking at soft tissue level. Let me get the poll back. And we're going to pick a different kind of question for this one. So here's the poll. You can click on it and move it out of the way so you can see the picture underneath. And the question is, based on all the variables you're seeing, the vestibular depth, the keratinized tissue, the attached tissue, recession level, the Chiro classification, what do you think would be the best treatment choice in this case here if we had to do some sort of treatment? So I'm going to give another 5 seconds, and I'm going to close off the poll. 3, 2, and 1. Let's look at the answer. So just more than half say free gingival graft, and just under half say connective tissue graft. So I agree with the free gingival graft group, and the reason is, if we look at this case right here in particular, or even here, if we were to pull on the lip a little bit more, you can already see a bit of blanching on the gingival margin. There's basically no vestibular depth in this scenario. So the key priority is always to make sure you have a vestibule of some sort. If you had the vestibule, then by all means, I would do a connective tissue graft in this case. So I also agree with the connective tissue graft group. But if the primary objective is to deepen the vestibule, which I think should be the objective in this case, I would side with the free gingival graft group. What about in this scenario here? What would be the best treatment of choice here? Let me get the poll, and whoops, and we're going to launch the poll. Sorry about that, I gave you the wrong poll again. And here it is. What kind of treatment would you utilize? This is the maxillary first premolar. And this one is pretty straightforward. Everyone, almost 95% got this one. It would be a connective tissue. And the goal here is to get root coverage as well as increasing tissue thickness, because you can appreciate how thin the tissue gets here, and we have lack of attached tissue. Just a quick side note, in the event when the poll's done, you can click on it to close the poll and get it out of your way so you can see the slides. When we look at a case like this, the question becomes, can we do a connective tissue graft in a molar area? And the answer is absolutely yes. We can do a connective tissue graft, get nice thick tissue. We can get tissue root coverage, but more importantly, look how thick the tissue is in this area. But if we put on our investigator hat and try to figure out what could have possibly gone on in this case, what could have led on to this scenario, when you look at the tooth, there's a story to it. And the reason the recession's only on the mesial root and not on the distal root is because the tooth is actually rotated. This is the mesiobuccal line angle, which has ended up on the mid-buccal of the tooth. Then you might ask yourself, why did this tooth rotate? And if you pay a little bit of attention on the distal side, we have a distal marginal ridge discrepancy where the distal aspect of the tooth is plunging downwards and causing the tooth to rotate out. So if I had to play an investigator role, I would guess that this patient's probably missing the antagonist tooth. The lower tooth is missing, and that's why the upper tooth is starting to partially erupt, because it has no contact on the distal. It probably has a bit of contact on the mesial. Distal side is erupting and rotating the tooth, exposing this area. So what would be the ideal treatment of choice once the soft tissue graft heals? Ideally, to try to rotate that tooth back into its position. If you're trying to look at this from a comprehensive approach, an orthodontic movement would be the ideal scenario afterwards. What about this case now? Let's make it a bit more tricky. What would you do in this case here? Let me get the poll. you know what? Before we do this poll, I'm going to ask another question. Let's launch this. What kind of chiro classification do you think this is? Let's start there first. Is this a chiro 1, chiro 2, or chiro 3? Because we have to establish the classification before we decide what we're going to do, right? So 3, 2, 1, let's take a look. So 80% got it. It's a chiro 1. That's absolutely correct. So now that we know it's a chiro 1, it tells us what? That we can do root coverage. So now that we know we can do root coverage, and yet we see what we're dealing with the lack of, let me just launch this here. We know we have a root coverage that's amenable. We have a recession that's amenable to root coverage because it's a chiro 1, but we have thin tissue and we have minimal attached gingiva. What are the treatment options we have? Gets a little bit more tricky in this one, right? So let's end this in 3, 2, and 1. And the slight majority said connective tissue graft. And I agree. Can we do a connective tissue graft in this? Absolutely. These are the best cases for a connective tissue graft. We can actually increase the amount of keratinized tissue if we modify a connective tissue graft technique where we leave a band of tissue exposed of the graft. We definitely thicken the tissue. Look how much thickness we have down here. It gives us volume, and it allows us to get nice, beautiful root coverage and a tissue that blends in. Could we have done a free gingival graft? Absolutely. We could have done a free gingival graft in this case. Problem would have been, it wouldn't have been as aesthetic. And number two, the tissue root coverage probably would not have been as high, because to do this with a free gingival graft, we needed to have thicker, broader interdental spaces to be able to place the graft fairly high. Otherwise, we're kind of bound down here. So then aesthetically and a root coverage perspective, the free gingival graft would not have given us the level of coverage that we wanted. Now, what about in this case? Let's pull the poll. So you know the first question is going to be, what kind of chiro classification is this? It's the first thing we got to know. Is this a chiro 1, chiro 2, or chiro 3? I'm giving you a tougher case. So you should all be asking me one thing. What's the x-ray? Because ultimately that's how you can tell where these levels are at, right? So if it's a chiro 1 or a chiro 2, when it's hard to tell, you need the x-ray to see the proximal bone levels. So let's look at the answer. Majority said, so 2/3 said chiro 1, 1/3 said chiro 2. And I totally understand, because some of you are thinking, well, we've got a bit of interproximal loss here. So this is a borderline 2. I could give you that. If you said 1, it's fine. If you said it's a borderline 2, that's fine as well, as long as you can interpret the answer, because the answer is ultimately going to be, can you get root coverage? And if so, how predictable is your root coverage? That's the clinical implication of establishing classification. Classification without clinical implication doesn't really mean anything. So now that we've established that, what procedure would you do in this case? Free gingival graft or a connective tissue graft? Let's end this poll in 3, 2, and 1. And share the results. So we've got about 2/3 said connective tissue, 1/3 said free gingival graft. I'm only getting about 1/3 of you that are actually taking the polls. 2/3 of the people are not even participating. So maybe you're on a device that's more difficult. But coming back to the question, absolutely. So this was done in a connective tissue graft technique. You can appreciate the root coverage, the nice aesthetic result. However, remember, for those group of you that said this was an RT2, and I said that's what I would predict, but I can kind of give it to the RT1s as long as you know what you're dealing with. Look at the interproximal and look where our tissue ended up. We don't have 100% root coverage. We've got about 90% root coverage. Is that fine? It's absolutely fine as long as you know that's what you're going to get. Because when you know where you're at, you can tell a patient, you can align your expectation and patient's outcome expectations together. You don't want to guarantee root coverage on a case which is an RT2 and not an RT1. So just always be mindful of that. Could you have done this with a free gingival graft? Absolutely, but you could not have gotten any root coverage in this case. It would have increased the zona keratoid tissue, would have deepened the vestibule, but I don't think vestibular depth is a problem in this particular case. This is another example. The area is treated, patient comes in for annual follow-up, look at the plaque buildup. That's not a good sign. If that keeps progressing, what's going to happen? We're going to get further tissue breakdown eventually down the line. So these are things that we need to train our staff to be able to flag these. What about these famous class 5 lesions and with composite restorations? So here's the thing. Think of class 5 lesions as non-teeth problem. Think of them as gum problems. So if you have a class 5 restoration that needs to be replaced, and if it falls within the boundaries of your tent poles, the best way to treat these is to simply remove it and do a connective tissue graft and cover it right back up. If you have a case of RT1, you do that all the time. If you have an RT2, what you need to determine is where is the carious lesion or the composite filling relative to your tent poles. Because if part of it is coronal to the tent poles, you know, based on the literature, we cannot go higher than the tent poles. You cannot put up a 6-foot tent on 4-foot tent poles. So if your lesion is further up, that part will have to have a composite restoration, maybe a veneer, maybe a crown, but the apical part can be treated. So those are cases where the complexity becomes higher because now you're doing a multidisciplinary approach. But any case where you have an RT1, you have a composite class 5, and you're contemplating which to do, the best way to treat it is with a connective tissue graft, because that graft will stay there much more predictably than a class 5. Because what's the problem we get with class 5 typically? We get marginal leakage because it's composite on the worst possible area. Not only is it wet, because most of the time these are root surfaces, it's not enamel. Number 2, we get tooth flexure, and we've got massive amount of gingival fluid constant bathing that filling. So keep that in mind, but also remember we can never do connective tissue grafts on top of a composite restoration. It will never work and it'll never develop, and it could actually lead to further problems. Can we do this on the lingual? The answer is absolutely yes. The same process, the same protocol. I don't want to keep berating the point. Connective tissue underneath, the area is left exposed, and this is the stability we can get. Complete coverage in the area. Look at how thick and nice that tissue is. This tissue ain't going anywhere. It's going to be nice and bound down. Can we do this on the outside areas? The answer is yes. You can develop it. You can build it up and get a nice stability. Again, apologies for the mirror with the fog. So when we look at recession defects and not treating them, what does the literature show us? So untreated facial gingival recession in patients with good oral hygiene, in the long term, we will get increase in recession depth as we follow these cases. So we know, as a matter of fact, the tissue is going to gradually only get worse. If the recession's developed and it's there, even if the patient's hygiene is immaculate, the problem is going to persist. So knowing that and keeping that in mind, we need to monitor these patients more closely to know when's the best time to treat them if the patient's not ready to go right ahead for treatment. We need to also remember that the presence of keratinized tissue and greater gingival thickness decreases the chance of these recessions. This is the reason why we sometimes actually treat, and you might say, well, why are you doing a connective tissue graft if we have an RT3 case? We know we're not going to get any root coverage. This is the answer why. So in those RT3 cases where we know we cannot get any root coverage, but the residual tissue is inadequate, we can actually do a connective tissue graft to literally staple the gum where it is, not let it get any worse. We can't gain back what's been lost, but at least we cannot prevent it from getting any worse. This notion of a tissue barrier, which becomes even more important when we talk about dental implants, has been around for the past 40 years. And we know how tissue that has higher collagen and connective tissue is more bound down and it's more attached and prevents further breakdown around teeth, and even more so now around dental implants. This is the study I was talking to you about. Besada in 87, they demonstrated clearly that if you have to put a gingival restorative margin into the sulcus, submarginally, if you take two groups of patients, one with less than 2 millimeters of attached tissue versus greater than 2 millimeters of attached tissue, those that have less than 2 millimeters will have increased inflammation and higher subgingival restoration, breakdown, and leakage long term. So typically we used to say we need to increase keratinized tissue should be augmented, but now based on the literature we know it's not just the connective tissue, we need attached tissue. So it's not uncommon in these cases that we would do a connective tissue graft instead of a free gingival graft if it's any tooth in the maxilla, from 6 to 6, for example, from first molar to first molar. Unless you've got a smile like Julia Roberts, then we got to even do connective tissue grafts on wisdom teeth because they'll show. But aside from that, the literature is there. We need to cover these. We need to protect them to keep them under control, and to maintain them. So with that, we're going to go into the realm of dental implants, and I'm going to pass you along to Dr. Bemanesh, who's going to take over, and then I'll see you in a little bit later.
Good evening, everyone. Before we start talking about the management of soft tissue around implants, there was a very valid question that I choose to answer publicly because everyone might have that question. And it's if the patient has a very deep class 5 restoration with a deep prep, and we need to do a CTG on that area and you remove the restoration, what are we supposed to do? So cases like that, it's better you remove the restoration. You do your first of all, when you're doing a graft, you have to modify the edge of your prep to make it a little bit smoother. You perform your connective tissue graft, wait for 2 to 3 months of healing. Then the restorative dentist will cover the rest of the defect or the abfraction, whatever you want to call it, with a composite restoration. Now you have a thicker tissue, and if the restoration goes deeper, it's not going to bother the tissue. It's not going to cause further recession.
There's a question on that regarding resin-modified glass ionomers.
Yeah, and some resin-modified glass ionomers, like Jerry's store, there are some literature report on them that you get connective tissue attachment on it, meaning that the connective tissue fibers would go directly and attach to it. So if you have cases like a root resorption, like external root resorption, you can use it for repairing the resorption and performing connective tissue attachment on it, but the attachment is very weak. It's not like connective tissue fibers attaching to cementum. So let's talk about the soft tissue management around implants. So let's talk about the biology of peri-implant soft tissue because it's kind of different from peridental or periodontal soft tissue. The gingival biotype, it plays an important role in implants. The biologic width is different around the implants, and we're going to talk about some soft tissue augmentation techniques around the implants. So first of all, the mucosa that encircles the teeth is different from the mucosa that encircles the implants. The mucosa that are around the teeth, they have more vasculature, they have less collagen fiber. The one around the implant, it has more collagen fiber, fewer fibroblasts. Also, as you all know, the collagen fibers around the implants are not inserted perpendicularly to the implant surface or to the fixture or abutment surface. They're running parallel. It's a non-functional attachment. However, in teeth, they're called Sharpie's fibers when we're at the PDL space or at the supracrestal space. They're called collagen fibers or supragingival fibers, and they're perpendicularly attached to the implant surface. Now, as we talked about, since this system is running different and the surface characteristics of the implant, what kind of titanium characteristic we have is different, plays an important role in the attachment, and also the mobility of the soft tissue plays an important role in the attachment of the tissue to the implant as well. So if the tissue is more mobile, these fibers are not going to be as firmly hugging the implant surface. And the only surface so far, based on literature, that shows some perpendicular attachment is laser lock implant surface. So in literature at the research level, they realized that the laser lock implant color causes the collagen fibers to go perpendicularly as opposed to parallel. However, again, the attachment is super weak. It's not comparable to a natural tooth at all. And it's not a true hemidesmosomal attachment at all. They're just inserted, they just go vertically. They're not embedded into the titanium surface. As far as the vasculature is very different in the tissue around the implant. Why? Because usually by the time you have a restoration placed on the implant, that tissue is manipulated multiple times. You have the implant extraction bone graft, then implant placement, then stage 2, impression taking, insertion. So the tissue has kind of like scar tissue, and it's less vascular. Also, we have the junctional epithelium. We have a junctional epithelium both around the tooth and the implant. We also have a subepithelial connective tissue both around the tooth and the implant, in which we call them biologic width. Biologic width in general around the teeth is smaller than compared to the implants. Around the teeth, based on some Gargiulo studies or Lescarin studies, on average is about 2 millimeter, 1 millimeter connective tissue, 1 millimeter junctional epithelium. In implants, it can range 4 to 4.5 millimeter. Now, the other major difference is that we have PDL space around the teeth, and the PDL space is a very vital tissue. It has a lot of vasculature. It has a lot of active cells, like mesenchymal cells, which contribute to the repair and the healing process. We don't have that around the implants. And a lot of vasculature that is coming from the periligament or periodontal space contribute to the bone stability around the implant, natural teeth. In implants, we don't have that vasculature supply. We don't have the PDL space. So it's a different environment, and as a result, we're more prone to bone loss around the implants. Also, because of that major difference, implants are more prone to occlusal trauma compared to the teeth. Teeth, they have PDLs, which is like a natural shock absorber. It takes a while for a tooth to become mobile due to occlusal trauma. But for an implant, you can easily lose osseointegration if you have heavy occlusal forces because they don't have the PDLs. So if you want to take a screenshot of this picture, this is basically a briefing of the different major differences between periodontal and peri-implant soft tissue. Now, the million-dollar question is the keratinized tissue around the implants. For years, that was always a controversial topic. Some clinicians believed in it, some don't. Now we have enough body of literature that tells us that it's very important to have adequate keratinized mucosa around the implants, to have a stable implant, to have a stable bone support around the implant. And that thick mucosa creates a seal and prevents bacterial destruction and tissue damage around the implants. So this is the list of the studies, the systematic reviews that prove if you have adequate keratinized mucosa, we have less plaque accumulation around the implants, we have less tissue inflammation, and we have less recession and loss of attachment. And patients are going to be much more comfortable performing oral hygiene around an implant that has a thick tissue compared to a thin tissue. So again, this thick tissue, it creates a tight fibrous collar around the implant surface, so bacteria cannot get in easily. And also when the patients are performing oral hygiene, they're not going to feel sensitive. You can imagine if you have a very thin alveolar mucosa sitting on a metal surface, as the patients are brushing the area and pressing that tissue against the abutment or even the exposed threads of the implant, it's going to be uncomfortable. So they automatically avoid the area, and it becomes like a vicious cycle. Also, when you're going through the restorative maneuvers to take an impression or place a new crown or temporize it, the tissue doesn't get inflamed, doesn't recede as easily. You are thick, healthy tissue. Now, before, the success definition for an implant placement was just achieving osseointegration. These days, that's not enough. We are in the era of selfies, aesthetics, and everyone cares about the looks. So we want the implants to look as natural as possible. Now, implant aesthetics comes not only from marginal bone, but also firm papilla and management of soft tissue. It's actually trickier to manage the soft tissue around the implants than managing the bone. We're going to talk about some biologic principles that will help us to manage the soft tissue better around the implants. First of all, marginal gingiva around the implants is influenced by different factors. It influenced by periodontal phenotype, whether you have a thick or thin phenotype, width of the facial bone, or in general, the bone that is surrounding the implant plays an important role. The micro and macro structure of the neck of the implant itself, and also the abutment is very important. The design and the material that your implant and the abutment is made of is very important. The distance between implants, everyone knows that's very important. And the implant abutment junction, and also the surgical techniques used to place and restore the implant is really important. So again, biologic width is junctional epithelium plus connective tissue around the teeth. We can say it's 2 millimeters of, on average, 1 millimeter epithelium, 1 millimeter connective tissue, and 1 millimeter for sulcus. Everyone has different biologic width. Like you have to basically probe and bone some people to get the different biologic width. But on average, we have 2 millimeter. Biologic width around implants is a different story. Some authors even say don't call it biologic width because we're not dealing with an actual tooth and the fiber attachments are not true fiber attachments. Let's call it supracrestal fibers. But for the purpose of this presentation and also in a lot of research articles, you see they still call it biologic width. The major difference between the tooth and the implant is that the biologic width around the tooth is always supracrestal, meaning that you have a crest of bone, then you have your connective tissue fibers perpendicularly inserted to the cementum, then you have the junctional epithelium on top of that. In implants, the biologic width is subcrestally. You all have seen it. When you have an implant, it's either like, if we're talking about a bone level implant, when we have a bone level implant and it placed at the bone level or slightly subcrestal, the bone looks good. And as soon as you put a restoration on it, when you look at it 6 months to a year later, you start seeing a little bit of cupping around the implant, which you can see in this picture. And hopefully that we call it cupping or bone remodeling. It's always 360 all around the implant. And the reason for that is one theory is the micro gap. Basically, as you put the your restoration on the implant, the microgap starts trapping and harboring bacteria and causes a minor inflammatory reaction, which causes the cupping effect or bone turnover. The other theory is it's a biologic width formation. Basically, when we put a crown over the implant, the body wants to recreate the seal around the implant. And for creating the seal, we need space. We need space for junctional epithelium. We need space for connective tissue fiber. And if the tissue that is sitting on the crest is not thick enough, the space is created at the expense of resorbing bone. So before we knew that we need to have good thickness of tissue on the buccal surface or on the lingual surface. Now the importance of the tissue on the crestal surface is more studied and proven. And studies shows that the implants that have a thicker tissue at the crestal level show less bone loss when they're restored, because they have that tissue thickness gives them enough space for the biologic width formation. So again, if you look at this picture, as soon as this implant is restored, in order to have space to create this connective tissue attachment and junctional epithelium, the bone goes down. So a lot of times, depending on which area in the mouth we're talking about, even for bone level implants, we choose to put it subcrestally. And in anterior region, sometimes way subcrestally because of the running space, emergence profile. These are the factors that we can talk about the whole day, get the aesthetics we want. So again, this picture shows that the biologic width is always supracrestal around the tooth. However, around the implant is subcrestal. So bottom line is put your implants, if it's a bone level implant, slightly subcrestal, and make sure you have adequate tissue thickness on top of your implant, so there is enough there's enough room for the biologic width formation. So the studies, again, this is emphasizing the study that when we have thicker peri-implant tissue, we have less radiographic bone loss. The other thing is abutment height. Some studies and some authors claim that the abutment height plays an important role. And the longer the abutment, the less marginal bone loss you have, which kind of makes sense because, again, when you have longer abutments, especially if the abutment goes a little bit subcrestally, you have more running space for that biologic width formation, so you're not going to have as much bone loss. Now, how much tissue? So this is based on the current AAP classification and based on the systematic reviews that we want to know how much tissue we want to have. First of all, we want to have 2 millimeter or bone band of keratinized mucosa, and at least 1 millimeter of it should be non-mobile, meaning it should be attached. We're talking about apicocoronal direction right now, not buccolingual. So apicocoronally, we want to have at least 2 millimeter width of kg, and 1 millimeter of it should be attached. As far as thickness, of course, the thicker the best, at least 2 millimeter. Supracrestal fiber attachment or vertical tissue height ideally should be 3 millimeter or more, and buccal bone thickness should be 2 millimeter or more as well. So with the bone on the facial, with the tissue on the facial, the more the merrier. And why we're just so crazy about the facial bone is because, again, we'll discuss that in the other course, which is our traumatic extraction course. The amount of bone resorption and thinning is more on the buccal bone or facial bone compared to the lingual or palatal bone because of the anatomy of the buccal or facial bone. There is less trabecular, less cancellous, less blood supply, so it easily collapses. So you always want to make sure you bulk up the bone. Plus, the facial bone or the buccal part is the part that actually patient sees in the mirror. So you want to make sure you don't have a concavity or the dipping after the remodeling. Now, when is the best time to augment the tissue? There are 3 ways to augment the tissue at the implant site. Either before implant placement, meaning when you're doing your extraction, ridge augmentation, you can do a connective tissue graft on top of it to thicken the tissue. You can do it at the time of the implant placement when you submerge the implant, or you can do it at the time of the phase 2 surgeries. Now, studies show the healing and the result that we get with the connective tissue graft around an implant that is already restored is not comparable to a natural tooth. And again, this comes from the fact that the tissue is different. The tissue around the implant is more like scar tissue, is less vascular. So before we manipulate it too much and restore it, it's better to thicken it up. What's the best method to gain the connective tissue attachment or to thicken up the tissue on the buccal? Studies show the best thing is the old connective tissue attachment, connective tissue graft. Subepithelial connective tissue graft is the best method because not only it increases the thickness of the tissue, it increases the band of attached tissue and keratinized tissue as well. Now, some situations we cannot use connective tissue graft because sometimes we need to deepen the vestibule, especially in the areas of complete or partial edentulosum when we are using locators or any removable appliance sitting on top of the implants. In that case, it's better to use a free gingival graft technique to not only get the thickness of the tissue we want, but also to deepen the vestibule. And that's a perfect example of the case here. We had to do 2 big free gingival grafts, and you can see before and after the vestibule is deeper, so it's easier to put a flange on the future prosthesis, and the tissue is also thicker and firmly attached to the teeth. Now, in this case, the tissue was not managed before the implant placement, and as a result, we got some recession. The implant threads got exposed, and the best way to improve the prognosis of the implants was to smooth the exposed threads, because we all know the exposed threads are going to harbor bacteria and continue to the peri-implant bone loss and peri-implantitis. But we want to prevent further recession and further bone loss. So what we do, we need to thicken the tissue at this point. So in this case, we're going to do a connective tissue graft around the implant. We flap the area open, Usually we do a full thickness flap. In this case, we're using some biologic factors, and you suture the graft itself around the implants, and then you suture the flap on top of that. And you wait for about 8 weeks of complete healing. And here you can compare before and after. We have thicker tissue right now. We have thicker volume of tissue. It's more attached tissue. And as a result, but by the way, this gray material is not the implant threads showing. It's not amalgam tattoo. We call it titanium tattoo. Basically, when they were removing the threads on the implant, the titanium particles got stuck on the tissue. So that's what's showing on the tissue. One trick to, sorry, there is a question. Where to get the CTG from? So the one question that everyone is wondering, where to get the CTG from? I know some people, some clinicians like to take the CTG from the tuberosity area, and some people like to get it from the palatal area. I mean, the lateral side of the palate. I prefer the palatal vault, because you have more tissue. If you're doing connective tissue graft on just one tooth and the patient has adequate tuberosity tissue, by all means do that, but it's harder to access, and also as far as the length of the tissue is limited. If you're doing multiple teeth or around the implants, I always use the palatal vault. The other thing is always try to use thicker tissue. But by thicker, I don't mean to compromise the thickness of the remaining tissue on the palate and cause some tissue necrosis on the palate, because it's going to be extremely painful for the patient. If you have thick tissue to deal with, get the thickest tissue possible. Why? Because the recipient side, again, doesn't have good vascular supply. So let's bring a tissue that has a lot of vasculature, a lot of capillaries to the area, so we can take advantage of that plasmatic circulation. Whoops, I went one slide too far. Now, how do we do papilla formation around the implants? So papilla formation around the implants can be tricky. It's, again, depends on a lot of factors. It's the thickness of the soft tissue, how the implant is placed, how deep is placed, what's the distance. And again, it's a one-day lecture on how to recreate papilla and gingival scalloping on the implants. But the very first thing we need to have, a very important thing we need to have before anything, is the thickness of the tissue on the crest. We need to bulk up the tissue on the alveolar crest, because the bigger tissue, the thicker tissue we have, we can manipulate the tissue easier and recreate the papilla. Basically, we can squeeze the tissue. So I'm going to show you a clinical case of how we manage basically recreating the lost tissue. So this patient fell downstairs and the tooth was avulsed. And I saw this patient about 2 to 3 weeks later. As you can see, the tissue already has collapsed on the area. The papilla is almost gone. And when we flap the area open, you see the buccal bone is completely gone, and we have to do a ridge augmentation. We use autodensification technique to place the implant, so it's always possible to place an implant even if we don't have bone on the buccal. So we use the palatal bone, which you're supposed to do in an immediate implant case on the incisor region. We place the implant and we have to augment the area. So I do the ridge augmentation by adding a particulate graft material and covering it with resorbable membrane. However, I want to bulk up a soft tissue on the area. So one way to bulk up the soft tissue is by using the VIP CTG, which stands for vertical interpositional pediculated connective tissue graft. So we're harvesting the tissue from the palate. We go under the flap and dissect it, and we rotate it and we put it under the ridge. Again, it's hard to explain it in the webinar. It's usually in hands-on courses. We do that, and we, as part of our ridge augmentation procedures on the maxilla, we always try to do that to make the tissue thickness more, and after that we have more tissue to deal with. So this is about 3 months after healing, and as you can see, the tissue is thicker, the tissue has traveled down more apically, and when we go in to expose the implant and we put a temporary crown on that implant before we move on to the permanent crown, we have more tissue to squeeze and recreate the papilla. This is another case. Again, the patient had lost a tooth. Two ridge augmentations were done using a xenograft material, and it kept failing. And as a result, you see the tissue is more scar tissue. It's very fibrous, and the patient, as a result, got a lot of recession around the adjacent teeth. So what we decided to do here, not only we redid the guided bone regeneration again, we did that VIP CTG technique to bulk up the tissue, not only around the teeth, but also on the crest. So when we go in to place the implant, I have healthier tissue or more volume of the tissue to deal with. And these stains on the teeth are due to chlorhexidine rings. If you're wondering. So in conclusion, we need more around implants to achieve a successful outcome. It's not just about osseointegration or lack of pain or lack of bone loss. Aesthetics plays an important role. Part of the aesthetics comes from the management of the soft tissue around the implant. So we need to know the biology of the soft tissue, the biology of the healing around the implant in order to achieve these results.
So in summary, we looked at the different possibilities of treatment modalities that are out there that are all evidence-based treatment modalities, basic definitions, solutions, and treatments, biologic principles as it correlates to when and where you can do a procedure, either around teeth or around the implants. And we looked at some treatment algorithms. Now, hopefully, if this is something that interests you, that you enjoyed, when we did the other webinars, people kept asking about a hands-on solution. Stay tuned. Hopefully, when this whole crisis is over, we can maybe cater to some sort of a hands-on opportunity. But until then, the best we can do is try to learn from each other using different webinar solutions. With that, I'd like to thank you all for joining us on a Friday afternoon. This is the code that you will need to put in order to get your CE certificate. Now, kindly do remember, we ask for those who request a CE certificate to also make a donation to the Cedars Cancer Foundation, especially during these times of need, to help out the most vulnerable amongst us. On behalf of the Cedar Cancer Foundation, both Dr. Bemanesh and I would also like to thank everyone again for participating. And at the end of the day, this is the reason why we're all here today, to try to raise funds for the Cedars Cancer Foundation. Now, before you leave, there's a couple of questions, and we have a couple of minutes left we can go over. One of the questions was, at which point in your treatment algorithm do you do these procedures, the site augmentations and the connective tissue graft? Connective tissue graft is part of your foundation development. So typically it's done before the implant placement. So when you're talking about developing your bone or developing your soft tissue, this should be done before your implant's placed. In cases where you're doing an immediate implant placement, then it would be done at the same time as a surgery. So that last case that Dr. Bemanesh showed you with the recession on the adjacent teeth in the front, that case actually got the implant placed in the central, had a bone augmentation done in the central, a VIP connective tissue was done on the implant, and a traditional connective tissue was done on the adjacent teeth, and everything was brought down. So that's what allows you to develop a site. So all you have to do afterwards is to go in, do a little small punch, and deliver your temporary crown, and then develop the site from there. Another question that was asked was, where do you get the connective tissue graft? Actually, I think that was answered already from the palatal vault. We talked about Jerry's store. I think we covered all the other questions.
There was a question about alloderm or allograft case, which I can answer.
Oh, go ahead.
So there was a question about using allograft material, or everyone knows the brand name Alloderm. They have their own use. However, more recent systematic reviews show that in long term, we have more thickness of tissue with autogenous graft, meaning the graft that is coming from the palate. Because when you use an alloderm material, part of it gets resorbed as a result of healing. However, it has its own indication. For example, we have patients who are severe gaggers, or even under IV sedation, we can manage the gagging, so we have to use the alloderm tissue. Or we have some patients that have some genetic disease of the connective tissue origin, like Ehlers-Danlos syndrome. So in these cases, we want to minimize trauma to the patient's mouth, so we never go to the palate. But if you have a healthy patient, a healthy candidate, connective tissue graft is a gold standard.
you got to remember, from a healing perspective, from a biological perspective, if you use any sort of allograft material, either be it alloderm, dermis, I'm drawing a blank with the other names. There's different varieties of them. They all come from a tissue bank. Your thickest amount of tissue is going to be the day of surgery, because with time, as that area granulates in and the tissue comes in and your graft gets resorbed away, your tissue never gets thicker over time. In contrary to an autogenous graft, your thinnest amount of graft tissue is the day of surgery, because with time, a lot of you may have seen, it kind of looks like a tumor almost sometimes, where they grow really, really thick and you develop a ledge in those extreme cases. But the tissue keeps getting thicker and more rugged and more fibrotic with time, so it gets more bound down. That concept of a fibrotic band we're talking about earlier, you get to see, you tend to see that much more with autogenous graft versus allogenic graft. I think that's pretty much it. And we're
one last question.
You have another question? Go ahead.
Would patient tolerate recovery without surgical stent? Yes, but they're much more comfortable. They always say it's a night and day difference when we put a surgical stent on the palate, or we call it palatal guard, to protect the area. Because at the end, what gives them pain is their tongue as they're talking or eating. It's touching the area. Plus, it prevents them touching the area by accident and causing bleeding. So honestly, we have tried different modalities, and I know different clinicians recommend different things using tissue glue. But what we recommend doing is always suturing the palate and then delivering a palatal guard right after, and having the patient wear it for at least 24 hours and don't remove it. That's really helpful with the patient's comfort.
I got one other question in terms of where or how to make the donation, in case you haven't done it already. The easiest way, you can go to our website. That's chirurgieziba.com, chirurgie.com, ziba.com. You will get the question, I believe, the link sent to you probably by one of the questionnaires you're going to receive. Go under webinar, and there's a direct link where you can click on donate, and it takes you directly to the Cedars Foundation in order for you to make your donation and get your CRA tax receipt as well. So if there's no other question, I don't see anything else. Do you see any questions coming up? If there's no other questions, then please don't close your window. Make sure you keep the window open. Once we log out, you will be directed to a page where it'll ask you for the CE code so you can register. Our next upcoming webinar is next Monday, or this coming Monday at 6 p.m. Eastern Time. It is on diagnosis and management of peri-implantitis. And to all of those on the East Coast, have a wonderful evening. On the West Coast, have a great afternoon. And I think we got one more question.
Yeah, about CEs. Don't worry if you have not got your CE certificate from Dentsply yet. As you know, they're all working with limited forces from home, so for sure you're going to get it. If by next 2 weeks you didn't get your certificates, definitely shoot me an email or message me on our social media, and I will contact them. So the lists are submitted. They're working on it to issue your CE certificate.
I believe they're going to be sending them out early next week, and once you make the donation, they're going to allow us. Send us an email or just on Facebook, or private message on Facebook or Instagram, and we let them know, so then you can get that certificate as well. I think that was one of the other questions. Have a great one, everyone. Stay safe and healthy, and have a great weekend coming up. Bye now.